Just to start the discussion, I would like to comment on the last part of the presentation. I would like to remind that as the food supplements are not practically tested, but are just notified in any market, more or less the same is happening with the e-liquids. It doesn't mean that the products are not safe.
But it doesn't mean they're safe.
No, it means that the government should make the system to check and to verify that what the producers are giving is correct.
I agree completely. I mean, that was the comment, because you have 1,000 supplements, but when you get FDA to check them, a 10% finds out to be completely different. Yeah. Probably that would be the case. It's not a total category.
Correct.
It's that in general, health, either supplements or e-cigarettes should not notify. They should also be checked to see that what they prescribe is real.
So, we have so many.
Let's start.
Yes.
I do have some comment to make. I fully agree with the uncertainty. And I also agree that the EU has created a regulation. Basically, it's the only region in the world where there is regulation which has already been implemented for 3 years in every member state. The
problem is not that the government in any country is not responsible for testing all the products, because this is something that no one can do. There are so many products, and that's also the same case for food products, for other consumer products. It is impossible for the government to test all the products. Otherwise, the FDA, for example, would not have asked for the PMI to do all these studies for IQOS. They would have done it themselves. They can't. The same applies for e-cigarettes. Too many products, the government cannot spend all that money to do the testing themselves. The problem is that, to the best of my knowledge, there is no system of randomly checking the files of some samples as they do for food products. You know, they take some random samples and they perform some tests to verify that the files are accurate and so on. I'm not sure if this is being done in Greece, and I think it is not. And I don't think that in Europe there is any country which is doing that. So I fully agree with you that now we have a large list of files and data available for all these products that mean nothing. No one is checking the accuracy of this information. I don't think, however, that by checking the accuracy, and even if we assume that everything is accurate, that we are going to establish the safety of the products. You know, we're just going to establish some quality criteria that the EU has set through the regulation. Establishing safety is something that needs a long time, as you said, and as everyone, I think, agreed, a long-term epidemiological evidence. So I think the question is, what are we going to do and what we should do, especially, for example, Greece with such a high prevalence of smoking, until we have all this long-term epidemiological data that everyone is asking for. And I think this is what we should address in this panel, one of the things we should address.
I think, can you hear me? Is this mic on?
Yes.
No?
Yes.
Okay, it's fine, it's good. We are talking about drugs, and particularly nicotine as a drug. The way the human organism works is that we never can have the craving for a substance. The pure substance is impossible for our senses to perceive. When we want alcohol, we are craving maybe wine if that's we want, or in my country sometimes harder liquor, and we crave particularly that. We don't crave a substance with a certain chemical position, etc. And that is the trouble here, that smokers are not having craving for nicotine, really. They might say that if we use that language and put them in the throat. They are craving an object. We are craving an object when we want caffeine. We don't want just the substance. And if I am really thirsty and want a cold Coke and you come with a warm cup of coffee, I get the drug. I want the Coke. And the same with the smokers here. So of course we can ask the smokers to switch from cigarettes to a patch, but that's a large, very large step. And some smokers will be able to do that, those who are maybe not so dependent and particularly very strongly motivated. So for the loss of pleasure, they make up with their motivation. But there is a continuum of motivation also. There are many smokers that just would like to keep on, but it's harmfulness. So yes, if I could manage my smoking a bit better, smoke fewer cigarettes. And in the other end, I suppose there are those who don't want any change at all. So we need an arsenal of products, I think. And the reason that e-cigarettes and heat but not burn has become so much popular than the NRT preparations, which are also on general sales in the European Union, is what I'm talking about. It's closer to their behavior which they are craving. Yeah.
So I'm going to address Konstantinos' point, which I've been thinking about. Can you not hear me? Okay. Which was about the testing of products. Well, in the UK, certainly we test all cigarette products 6 times a year for tar, nicotine, and carbon monoxide. Why, when we don't allow them to have those figures on their packets anymore? Because we discovered it was a bad idea, that was a bad regulation, we changed it. Why we do that is not entirely clear, but we do have a scope for testing, but what's the goal in testing e-cigarettes when we know that smoking, smoke tobacco is several orders of magnitude more harmful? I would suggest that the real regulatory challenge is, what architecture of regulation do you have in Greece that maximizes the number of smokers who stop smoking? End of. You guys have got a massive crisis. And I feel guilty when I say complacently, oh, well, every country has to find its own way, we all learn from each other. You guys have got a massive crisis on your hands. And you really have to find ways of radically reducing the numbers of people who smoke. And that's what your regulations should be designed to do.
Can I jump in that conversation, Konstantinos? Because I think it's also important to then address the issue that Greece is perhaps, can you hear me?
Yeah.
Greece, I've got this thing. Greece has, with the prevalence, I think what I heard all the day today was the existing smoking cessation clinics, for example, are either far too few or not necessarily appealing to the smoking population today. So I think we need a multi-pronged approach. We can't be just saying, look, e-cigarettes and heated products and something else out there is a solution, because the UK has come to that solution after trying everything. And this is now addressing the issue and the challenges of the remaining hardcore of smokers. Greece is much before that in the trajectory of reduction in prevalence. So we shouldn't ignore that cessation clinics are still perhaps the most proven place to advise smokers on NRT or varenicline or whatever else, but also then see if the clinics can be open-minded about harm reduction principles, including e-cigarettes potentially. And that's perhaps a more open-minded way. But that also will open minds among the cessation advisors to what harm reduction means. Because at the moment, I could hear that there is a resistance, a reluctance, because they're still far behind on the trajectory. That makes sense.
The problem is that, in my opinion, while I fully agree with you that we are far back in the trajectory, I think that should have been a motivation to do the exact opposite. Be more open to adding more options. And of course, I've never heard anyone, even the strongest supporter of harm reduction, saying that harm reduction as an approach in these products should substitute the other measures. Still, and I, in every opportunity, what I emphasize is that harm reduction is a third-line option for smoking cessation, with the first line option is being able to quit by yourself, the least successful way, and the second best option is go to an organized smoking cessation center, service, and get professional help, which includes both behavioral support and medications. We have quite a lot of smoking cessation services. I think the biggest problem is that they are not popular among smokers. This is not a Greek phenomenon, basically. It's a global phenomenon. But what was really interesting, and I witnessed, was the approach of the UK, where with the increased awareness and popularity of e-cigarettes, the smoking cessation services saw a massive drop on the number of smokers who were visiting and asking for help for from these services. And their reaction was to start a campaign where they were saying that we are, and I saw it with my eyes, with posters and ads, that we are e-cigarette friendly, and if you want to quit, because you can't force a smoker use a specific method. You must convince him that he wants to use the method. So they did a whole campaign saying that we are e-cigarette friendly, and if you want to quit with the cigarettes, we can't provide you the cigarettes ourselves, but we can give you proper guidance and support to be successful. Because let's not forget, any product, whether it's an e-cigarette or a heated tobacco product, it's not going to be successful to all smokers. Every smoker has different needs. And that's why I think we should support the availability of different products. Now, Martin, you said basically that even the worst quality e-cigarette is going to be better than smoking. And I agree with this, and I've written about it. But I don't think that this is an excuse to allow the availability of bad quality products. I think that there is a reasonable way of establishing minimum standards, and I think that everyone, including the smokers, deserve to have products available that comply with minimum quality standards.
Shall I say something about the effectiveness? You said that the least effective method of quit smoking is by... This is not true, because it has been estimated that about 3 to 4% of the smokers trying to quit smoking, they quit smoking successfully. This represents a huge number of smokers. That's why it's very effective. And it is not depend on pharmaceuticals products or nicotine or other. It's information, it's education, and it's a style of life. And I believe that this is a very effective method to quit smoking.
So that's the method I used when I was 30, and when I was 31, and when I was 32, and when I was 33, and every year until I turned about 40, because it's also the method that has the most failures. And I really wish that I had gone to the kind of service that would have increased the chance of each of my quit attempts being successful. So behavioral support plus the best device. I think we need to give each smoker in front of us the best chance of quitting successfully.
I agree. And it is very sophisticated to these steps in England coming to an end, coming to the stop smoking. There are several steps, and the final steps are the electronic devices or several other things.
Smokers, they differ from time to time also. You have a relatively high smoking prevalence in Greece. That means that it's nothing that just a small subpopulation is doing. It's in the general population. That was also the case in my country when I started to run the smokers clinic and see smokers. I saw patients from the entire society. But believe me or not, as the prevalence was ticking down, I didn't see any more medical professors or doctors or lawyers or et cetera, et cetera. And today, when we are down to 5-6%, whatever, almost every patient has a comorbidity of some sort, usually in the psychiatric sphere. It might be depression, anxiety, attention deficit, of course, schizophrenia, bipolar, they are very difficult, but also drug addiction, too much alcohol, chronic pain. So therefore, I actually tried to look at all the placebo-controlled randomized trials of NRT and also varenicline medications over time. And what I could see was that the results was quite high when NRT came up in the Western countries, US, Canada, Sweden, England, etc. And it's gone down over time. So you do not get that all the same effect from a nicotine patch in today's smokers as you got in 30 years ago smokers. So though stop on your own is quite possible here, it's really not very much possible any longer in Sweden.
Even here, I suspect, if I heard you right, given the absence of very stringent smoke-free policies, it's difficult for smokers, and if I understood correctly, it's difficult for smokers to want to quit because there is no social pressure. So I doubt if you would still have that environment where somebody just drops off smoking, because the environment is not necessarily conducive, is just my view on that. So they could still be open to an RT in other parts.
Yeah, I just want to address a different issue. A question was posed here, whether harm reduction is a moral issue or is it a scientific issue. I think that was a problematic question. If you juxtapose morality and science, and you know that those are not the controlling factors completely, because it seems as though what was forgotten in that question is that there's a strong political influence. I'll give an example that between 1995 and 2005, I used to represent South Africa on the Commission on Narcotic Drugs. At that time, 1995 to the year 2000, USA would not accept use of the phrase harm reduction because the implication for them at that time was needle exchange programs which they had not accepted. But of course, later on with the emergencies that came to emergency units, the thinking changed a little bit. During that period also, I think Martin will remember that cannabis was taken down to a lower scheduling, and then certain behavioral patterns, petty crimes increased in the UK, and then suddenly it was brought back to a higher scheduling. Now, this is really where the politicians need constant or consistent scientific information without saying we know the best, because if the politicians or governments do not support these programs, then we have a problem. If you look at what's happening in the USA now, the opioid epidemic, it's supported by government. They're putting a lot of money there. CDC is involved and so on. But that's because people who are dealing with that epidemic have not become enemies of government. They've tried to engage government positively. In South Africa, we tend to follow examples from the USA. If FDA says this, we are likely to move that direction, but we also follow examples from the UK. But when I asked Martin the question about what do you think helped to reduce smoking amongst adults in the UK, I think the issue of e-cigarettes was not a first issue. As you said, it was a total package, but it seems as though there was a lot of public education with clear facts, and because that was built into the first strategy that we had, education and education and education. And that means scientists should not be afraid to make mistakes. What you say today might be different next year. That doesn't mean you lied. It means you have new evidence, and you should be able to go back to government and say, things have changed, we found this and that and that. I'll be speaking tomorrow a little bit about smoking amongst mentally ill patients, because that's a dilemma in terms of whether we intervene with these newer products or not. Thank you.
Can I just make a point? There was a mention of data earlier, and I think I look at the UK as an outsider. I was looking at how UK over the last 10 years, 9 years, got the data to come to the position on, in this case, tobacco harm reduction. And Martin, correct me if I'm wrong, but I look at ASH data. So a local, very influential charity is collecting data every year from 2011, I believe, and you were one of the first authors of the 2011 paper that came out. and they looked for at least a representative sample of about 1,000 plus people every year.
10,000.
10,000, sorry. And that gave them enough confidence over years of data. So it's again mapping the trends of usage of e-cigarettes, that by the end of 2013-14, Ash was standing up and saying, look, we understand what this means for the smoking population. And maybe you can add to this, but this is important. The data is important to change government's thinking, and through that, scientists' thinking as well.
Well, the data is crucial, at least we hope it is. We hope that policymakers are constantly looking at the data, alert to the possibility that the data will change. But I think the Ash story is a good one. It's, we didn't have a lot of money, but we were able to get together this survey, which was a very pragmatic survey. The important thing about it was that we could change the questions year by year as we chose, but also we got the data really quickly. So, unlike the big cumbersome government surveys where it can take 4 or 5 years to change the questions and a year and a half to publish the data, we were deciding on the questions in December, going into the field in February, and using the data in April. Yeah? And so we were using real-time data about the same time that Robert West's Smoking Toolkit study, again, started publishing data month by month. That's the kind of data you need really quickly so you can make decisions in real time, and you're not making next year's solutions on last year's problems.
I had the opportunity, I was lucky enough to have witnessed myself the effect that data generation and analysis had on the opinion of UK scientists about e-cigarettes. I remember my first e-cigarette summit in 2012 when, just after my presentation, Linda Bolt was having a presentation from the University of Stirling, from Cancer UK, and she was very negative on e-cigarettes. She said, we cannot accept these products unless they are regulated as medications. The same was the opinion of Deborah Arno, the Director of Action on Smoking and Health. And what was very different in the UK was exactly what you said, Martin, that you had the data, you generated the data very rapidly, you had consistent monitoring every year, specific surveys, particularly and specifically addressing this issue. And in 1 year time, not more than 1 year time, Linda Bolt, for example, became one of the biggest supporters of electronic cigarettes. She is now designing a randomized controlled trial for pregnant smoking women to try in a trial use of e-cigarettes versus NRTs as a smoking cessation tool, which in Greece, if I would try to do that, I would probably end up in jail. She asked me 2 years ago to translate into Greek the official short guidance that the UK authorities have created for pregnant women. I told her I will need a very good lawyer and I cannot afford it, afford the lawyer. That's a big difference between the UK situation and the Greek situation. Unfortunately, in Greece, it's not only the smokers who need education. The healthcare professionals also need education. It is, in my opinion, unacceptable to have, after a preliminary study which was published from the UK, saying that comparing pregnant ex-smokers who were daily users of e-cigarettes versus smoking pregnant women and never smoking pregnant women, they found that the offsprings of women who were vaping had the same birth weight as never smokers, while the offsprings of smoking women had the 330 grams lower birth weight. This study is available, of course, not published, but in submitted and presented in a conference. At the same time, Greek doctors are suggesting to pregnant women that it's better to smoke 5 cigarettes per day rather than to try these filthy electronic cigarettes. This is an important problem that we are seeing not only with pregnant women, but also with people with other disease. Asthmatic patients is a characteristic example who have repeatedly received advice that it's better to smoke than to use an electronic cigarette, repeatedly, from respiratory physicians. And I don't know what's the basis of really suggesting something like that, because, you know, that's not a neutral position that I cannot recommend it as a physician. We're talking about basically and indirectly an active advice that it's better to smoke, you know, and it's something that we have seen repeatedly in Greece. So I think that the education should expand to the healthcare professionals who, of course, don't have the time to follow the research on a subject like electronic cigarettes. They have so many things to do. You know, they can't be every day on PubMed and look at every new study that is being published. So we need a better educational tool for the healthcare professionals too.
So let me just pick up on that question about medicines regulation, where we argued very clearly that e-cigarettes should only be allowed on the market if they were licensed as medicines, and anything else should be banned. Right? That was our position. It was the position that was adopted by Canada, by New Zealand, and by Australia. And we were wrong. And you know, in Canada and New Zealand and Australia, they realized that that meant banning e-cigarettes completely. In Canada, in New Zealand, they realized they were wrong, and they decriminalized e-cigarettes. And in Australia, they stick to that line, but you know, their smoking prevalence hasn't decreased, well, it's decreased 0.5% in 3 years. That's virtually nothing at all. I've got to say, we were wrong. We were wrong.
Can I add something? A comment. I don't believe, I'm a respiratory physician. We have the president of the Hellenic Thoracic Society. I don't believe that any respiratory physician has ever said that smoking is worse than cigarette. We have 1,800 respiratory physicians. We meet every 3 months. I've never heard it.
That
I've never heard it.
Smoking, you mean?
Huh?
That e-cigarette is worse than smoking?
Yes.
That's what you say?
Because you said, I mean, you mentioned that there are some respiratory physicians that they said it's better to continue smoking than go to a cigarette.
I expressed my opinion coming from
individual opinion.
From
I don't know if
messages
it's
that I have personally received from smokers, which of course is not documented, that I cannot prove it. So I will accept your remark, but
I've never heard it.
Personally, I'm sure it's happening. I don't know what
if there is one exception, it could be, but I mean, really, we've never heard it in any of our congresses. We never say it. We never advise it. It's something that should be an exception. And the second, about the e-cigarette in pregnancy, I think that it's a population that should be treated differently, because nicotine has effects on the embryos, and this is a different condition. And if a cigarette, I mean, if you can try in other populations, and they have tried in UK, and we see the results, I can understand it. But in pregnancy, we should be really harder. And I don't agree personally, since it's documented that it causes harm, to be so loose instead of prescribing NRTs that actually are short-acting and not patches. So I think that pregnancy, it's different.
NRTs are officially approved for pregnancy in many countries.
Yeah, France was first. France was first. NRT is approved for pregnant women since 1999.
It is also approved, but there is a difference. In NRTs in pregnancy, we are first of all advising to start with short-acting and not patches, and to have intense behavioral, and if the pregnant is not quitting in 2-3 weeks or reducing, then we stop it. So it's totally different. We can give, but it's not that we are freely giving NRTs, and also it depends in the trimester, because there is the difference. Why are you doing this? It depends from the trimester. It's not the same effect in the first trimester. It's worse in the third trimester to use nicotine. It has totally different effect according to the, and this is published, and it would be in DID, and I have a review, and everything is done. And,
And of course you're right.
So
Of course
I'm really sorry.
But,
It's proof.
but these women are getting nicotine. They're getting nicotine through cigarette smoke, right? And they're getting carbon monoxide, and they're getting tar as well. And you're right. I mean, by far the best thing would be for pregnant women to stop completely, spontaneously, without any additional support, just behavioral support without any medicines. And that would be the best thing if we can do that. But we're talking about women who haven't been able to quit. You know, most pregnant smokers will stop as soon as they discover they're pregnant. That's great. Others will try really hard and succeed, but there's a whole bunch, and they're the 10% that we're really worried about, that try but don't manage. And so with these, yeah, absolutely. So with these, yeah, absolutely. So with these ones who are persistently smoking, then we want to, what we have to do is allow them to minimize the harm. I definitely want them to stop smoking. But you know, if the way to do that is with nicotine, then that's better than them continuing to smoke, because then they're getting the nicotine and the tar and the carbon monoxide.
You should really try with behavioral, you should try with short-acting NRTs, and then you should try with e-cigarette. And I don't think that this is clearly so strongly recommended.
Well, that's a really positive thing to say.
This is your recommendation here in Greece.
No, it's
here in Greece, okay?
Not in Greece, not in Greece. I'm sorry, I'm not talking about Greece.
I think you missed a very positive thing.
I'm talking about international.
So I think Jacques missed your very positive thing that you said, that first, of course, behavioral support, then nicotine, and then if that fails, an e-cigarette, it might be necessary. And I think that's a great consensus, because, you know, sometimes for really heavily addicted, but that's what you said, I'm not misquoting you. And I agree completely with you. And you know, Jacques, I think that's okay, because we're agreeing that for heavily addicted smokers, sometimes an e-cigarette is the answer.
Yeah, but the problem is for all these women that couldn't stop.
Yeah, these are the women we're talking about. Absolutely, absolutely, we agree.
Just a bit of context on this, because again, back to the pregnant women issue in the UK. We hear about UK and the great progress in tobacco control, everything, the availability of stop smoking services. You saw the numbers from Martin. I'm going to present this tomorrow as well. If about 11% of women in the third trimester are smoking, despite all the stuff that's given and thrown at them, including midwives giving them support, there's about 10 organizations in the UK, including the Midwife College, the Royal College of Nursing. They have formed the Challenge Group, and I can share some of the references. Despite their work, and they had an ambition to have the smoking prevalence among pregnant women to go down from 11 to 6% by 2022. And you know what they're saying now? After 2 years in the project, they're saying, you know what? We're not going to meet that target. The admission of failure in a very ambitious project to get smoker women to be off smoking is already looking like it's not going to happen, because despite the availability of NRT, CBT, all kind of advice from their peer and their peer support, but also midwives, it's not cracking it. It's a very stressful period of one's life, as you can imagine. And I think that's part of the reason why pregnant smoker women really struggle. So I guess it only comes to option 3.
It's a window opportunity to stop smoking, and in many research and manuscripts, because when you are pregnant, you increase the metabolism of nicotine. It was because they did not give the proper dosages, and when they have done after meta-analysis or they have done trials with high doses, it had a success. Yeah. So it's not so easy to have conclusions. That's why we are saying.
But pregnant women have it's very limited what you can do with them. You can't give them oral medication, for example, which are by far more successful in smoking cessation.
Pregnant women that have got the advice and they know that they are pregnant, they are still smoking, is a very difficult group to care for. And I don't exactly know how many studies have been done, but certainly the majority of studies have failed to show any effect. And the recent one from France with Ivan Berlin as one of the authors also showed there was no effect of nicotine replacement. And I think it's because when you understand that you are pregnant, I mean, you have the strongest, best motivation that you could ever have. Yep. And if you sort of ignore that, or you don't ignore, but you can't, anyway, you smoke beyond that. That's why I think the results are so disappointing. That means that we need to understand that they need to be treated more intensively. And nicotine patches are allowed in many countries by medical authorities, but preferably the 16-hour patch, since we don't need to load them with nicotine during the night. I agree with Professor Casanuno on that. But if now I don't have any patients anymore, but if I had a woman that really cannot stop smoking and the patch or gums, some don't really want to chew gum, they can't chew gum, they get an upset stomach or whatever also, so we have a patch here, and that wouldn't be enough. I would not be too troubled by recommend e-cigarettes on top.
And there's a really big
equality. On top of the patch.
Sorry, there is a last for interrupting. After checking if they have depression, because there is a big sample that they have depression.
Yes.
And that's why in the United States they are giving bupropion that can be given like with recommendation B.
Correct.
So you have to check if the reason that she's not stopping is that she has depression. In that case, you give bupropion and you can give it in pregnancy. And then at I don't know, step 3 or whatever, you have tried everything, yes. But
so there's a really big equalities issue here as well. The women who persist in smoking tend to be younger mothers, they tend to be less well educated and poorer. They're the most disadvantaged mothers, but they're no less likely to want to quit. And they're no less likely to try and quit. But they're much less likely to quit successfully. And that's why we really have to put our backs into this and really work very hard, and in the end, offer them everything we can to help them to quit. And you know, an e-cigarette would not be the first thing I would offer a pregnant woman, but I would definitely hope it would be the last thing I would offer. Yeah, but I think we're agreeing, emphatically.
Absolutely.
Who thought that would happen?
Thank you very much all for first the panelists and the speakers.
For the first day.
For the first day, and the audience that stay here until that hour here with us. And now we're finished, and tomorrow morning at 9 o'clock we'll be here again.